Welcome to Derms on Drugs, a video podcast brought to you by Scholars in Medicine, the best educational platform in dermatology, and provided at no cost to medical providers. Derms on Drugs is where cutting-edge derm meets hit-or-miss comedy. I'm Matt Zyrus, and each week I'm joined by my residency buddies, Drs. Laura Ferris and Tim Patton. We use our 60 years of combined derm experience to discuss, debate, and dissect the hottest topics in dermatology. It is everything you need to know to be on the cutting edge of derm, and you'll actually have some fun listening. New episodes drop every Friday on Scholars in Medicine, Apple Podcasts, Spotify, and other major platforms. Just a reminder that we've got a video component. So if you want to see the key figures from the tables, go ahead and jump onto the Scholars in Medicine website. And as well, we've got all the links to the articles if you want to see the articles. All right, so let's go ahead and get into it. We've got one of our patented six-pack episodes where we're going to go over the 6 most interesting things we've seen in literature recently. Dr. Ferris, kick us off.
All right. I am going to be presenting a paper from the New England Journal of Medicine, Danny Rishin et al. And this is the results of the CPOST trial. So adjuvant Cemiplimab or placebo and high-risk cutaneous squamous cell carcinoma. So I've been kind of excited for this to finally get published, and it just did like 2 days ago. So this is a phase 3 randomized trial where patients were enrolled who had local or regional cutaneous squamous cell carcinoma after they'd already had surgical resection and postoperative radiotherapy. So these patients had to be, as you can imagine, at high risk for recurrence. And so the features that they used for defining high risk for inclusion criteria were either like nodal features, which were extracapsular extension with the largest node that was 20 millimeters or more in diameter, or with 3 nodes involved, or high-risk non-nodal disease, this kind of reason why I'm doing this is that I think we end up seeing a lot of these patients in dermatology, which was defined as any of the following: in-transit Mets, radiologic or clinical evidence of perineural invasion of a named nerve. So this is like big time perineural, T4 primary tumor, so with bone invasion, or local recurrence with at least one other adverse feature. So, so these are patients who were not just like, oh, is that a bad squame or not? Like these are pretty bad squames. And so other the adverse, features could be nodal disease, T3 lesion, or T3 or higher lesion, diameter greater than 4 centimeters, poor differentiation, recurrent lesion of greater than 20 millimeters. So those are sort of those, the local recurrent bad features. So patients were assigned 1-to-1 to either get adjuvant Cemiplimab, there's about 200 per arm, or placebo. So their dose of Cemiplimab was 350 milligrams every 3 weeks for 12 weeks. And then they sort of had this interim protocol amendment where they increased them to get 700 milligrams, but every 6 weeks. So, less frequent visits for patients. And so that was for another 36 weeks. So they were treated for 48 weeks total. Primary endpoint, disease-free survival. Secondary endpoint, freedom from local regional recurrence or distant recurrence. And then, of course, safety. Patients, had to have had both surgery with curable intent and, macroscopic gross resection of all disease and this post-op radiation therapy or chemoradiation at a biologic equivalent of at least 50 gray within 2 to 10 weeks before randomization.
In other words, these were people with really bad squames.
These are people with what we would consider pretty bad squames. Now, these are maybe people who we wouldn't have always done adjuvant radiation. I think this is sort of a sticking point of this trial is not every site would do adjuvant radiation after resection of high-risk disease, but they did have to have it to sort of have some standardization. So primary endpoint, disease-free survival. So that is the time from randomization to the first documentation of either disease recurrence or death due to any cause. And so if we look at the number of events, there were 65 events of recurrence among those who got placebo, but 24 in the Cemiplimab arm. So that hazard ratio for recurrence or death was 0.32. So that is a 68% reduction in recurrence or death. That is really, really, like, that's a huge hazard ratio for an oncology study. Secondary endpoints were freedom from local regional recurrence. And if we look at that, there were 40 patients in the placebo arm with local regional recurrence, 9 in the Cemiplimab arm, hazard ratio 0.2, 80% reduction, basically. And then the estimated percent of patients free from local regional recurrence at 24 months was basically 95% in the Cemiplimab arm versus 77% in the placebo arm, 0.35. So this was like a really statistically significant, highly successful adjuvant study, which is interesting. There were 2 deaths of people from each group. There were more grade 3 events in the Cemiplimab group than in the placebo. Of those deaths in the Cemiplimab arm, there was 1 pneumonia that was considered not to be related to Cemiplimab. And there was 1 death due to myositis, which was considered to be related to Cemiplimab. So that's kind of interesting.
All right. So Ferris, first, I have to ask you this every single time you bring these damn drugs up. What is Cemiplimab again?
Sorry, it is an anti-PD-1 drug. So it is
All right.
inhibitor of PD-1.
So it's one of these checkpoint.
It's a checkpoint inhibitor.
All right. So where's this going to be relevant, most relevant to derms, right? So we're not going to be prescribing this. Is it going to be in the category of talking to a patient who's got a high risk squam and be just so that we at least know, hey, there are some really good treatments for you if this goes south?
So, I think that there's a couple ways that this is relevant to us. I mean, one, this really reinforces the need for a multidisciplinary team to care for these patients. So, also realize that, Cemiplimab has also been shown to be very effective in the neoadjuvant setting. So, advanced tumor, give them Cemiplimab, then do surgery, or look to see if they look for evidence of response. And or now this is also showing that we can do this in the adjuvant setting. So do the surgery, maybe do the radiation if you're going to follow the protocol, do it the same way, then give them Cemiplimab. So, one, I think, like, we can't just manage these patients by ourselves. We need to have this
No, we
discussion
cannot.
with oncology, right? And then the other thing is that sometimes these patients, like, they won't go to oncology, right? And I just want it off right now. So we can do that, but we really should then be referring them for a discussion of adjuvant therapy after resection. Because, I mean, this was an incredibly successful response. Most recurrences were observed in the first year after resection, and in that completion of adjuvant radiation. So, this is also, like, we don't have years and years it's not like melanoma, like, these recurrences happen pretty quickly. So I think having that team on board is important. The other kind of fascinating thing I wanted to point out is that there was another phase 3 trial of adjuvant PD-1 therapy called Keynote 630. This was basically a similar study, but with adjuvant pembrolizumab, just a different PD-1 inhibitor. And that, we don't have a publication on that, but it was actually stopped for futility after it did not meet a pre-specified endpoint in interim analysis. So it's really interesting that 2 similar studies with 2 similar drugs had very different, outcomes.
It's like completely and totally fascinating, right? I mean,
Yes.
because Cemiplimab and Pembro, they are FDA approved for some similar cancers, right?
Yep.
Metastatic squamous, non-small cell lung cancer. And it's not like there's a huge difference in their effectiveness in those particular cancers. And people are talking about, like, well, this is the importance of trial design. But man, how would you go from 68% reduction to stopping a trial because of futility solely based on trial design. Is that possible? Does that make any sense to you?
Yeah,
Anyone?
I don't know, and I haven't seen the Keynote 630. This is basically press release level data. I don't, there has been, I think that you had to have slightly more advanced disease to go into CPOST, the one that I just talked about, than you did for Keynote 630. So,
Right.
therapies work in patients to see a reduction in death and recurrence. You need to have a high risk of death and recurrence in the first place. So maybe that was it. It was just a higher risk population, but,
Hmm.
fascinating. And, not a huge study, but in terms of safety, but, I think it's going to be interesting to see how we do this. And I just think also, like, for derms, we cannot be like, if I can cut it out, I'm the doctor who treats it and we're done, right? Like, we really need to be taking care of these patients in a multidisciplinary setting, and being the greatest Mohs surgeon in the world who can cut out the biggest thing and go down into the parotid and into the neck, is not enough. That doesn't mean you can be their only cancer doctor. To me, this really says, we need to be able to offer this option to our patients.
Do we send people to a medical oncologist for this, or?
Yes. Medical
Okay.
oncology would be the one who would give this. And,
Yeah,
my
I
plug
mean,
for multidisciplinary care, it doesn't have to be like we all sit in a room and look at things, or, this is like, we can all get on Zoom. You can have a multidisciplinary tumor board through Zoom. You can all be in different locations and share photos or scans or have discussion and, triage the patient. You don't have to be in an academic medical center. It can be, this is my good medical oncologist, this is my surgical oncologist, and, and I'm the dermatologist, and it can be as simple as that. So I think it's important that we really start working toward giving this level of care to our patients.
All right, Patton, what do you
yeah,
got?
my first six-pack article, pre-proof article, published online JAD May 2025. It's by Cow et al. It's titled "Efficacy, Safety, B-cell depletion capacity of 3 rituximab dosing regimens in the treatment of moderate to severe pemphigus vulgaris and pemphigus foliaceus," a 52-week clinical trial. It was a single institution, prospective, open label. Patients had to have moderate or severe PV or PF, had to have inadequate disease control with corticosteroids and immunosuppressants. The immunosuppressant medications, specific doses, specific medications weren't specified. Difficulty tapering steroids, they did not really define that either. Patients received systemic corticosteroids, 0.5 mg per kg for moderate disease, 1 mg per kg for severe disease, and also received rituximab on days 0 and 15. And the doses of rituximab varied. Standard dose, which is 1,000 milligrams, 2 doses, 2 weeks apart. Low dose, 500 milligrams, given in the same regimen, and then ultra low dose, 100 milligrams. Because of a higher percentage of B cells tested at week 26, patients in the ultra low dose group got an additional dose of 100 milligrams of rituximab at week 26. So it was kind of like 2 doses for those higher doses, 3 doses for the group that was in the 100 milligrams. 26 patients in the 100 milligram group, 13 each in the 500 and 1,000 groups. Table 1 lists all the baseline characteristics, and there may be some differences in the groups, but none of them reached statistical significance. A couple of numbers stood out to me. Patients in the 100 milligram group had a disease duration of 18 months versus 36 months. That's a huge difference. Again, didn't reach statistical significance, so maybe it doesn't matter, but that number jumped out at me. Baseline prednisone dose varied from 20 milligrams in that middle rituximab dose group up to 40. I think that's a big difference, but I don't know, maybe it's not. Primary endpoint was remission after disease control. So disease control, no new lesions, old lesions starting to heal, and then you start to taper the steroids. And then the authors looked at who goes into remission following that point. There were some secondary endpoints as well. Primary, secondary endpoints all measured at week 52. So table 2 goes through those. Every group achieved disease control. Almost every patient achieved complete remission. It was 13 out of 13 in the 2 higher dose rituximab groups and 24 out of 26 in the 100 milligram groups. This wasn't considered statistically significant. And the only statistically significant difference between the 2 was in the number of days to achieve disease control, but it was a difference of 1 day between groups. And I don't think that that's clinically significant. Everything else, cumulative steroid dose, time to complete remission, percentage of patients that relapsed, et cetera. No statistically significant differences between the groups. Serious infections occurred in 15% of the standard dose, almost 8% in the 500, and no serious infections in the 100. None of the adverse events were significantly different between groups. No mortality or withdrawal because of adverse events was reported. So it seems like, basically low dose 100 milligram. I mean, that seems like a reasonable option because of that because of the additional dose that they had to get at week 26. Maybe I'm not going all the way down to 100 milligram dose, but I think the next time I treat a pemphigus patient, especially if it's not like, the worst pemphigus patient that I've ever seen, I think I might do those 2 doses at a lower dose, like 500 milligram, and just kind of see what results I get. I mean, it's not going to be an issue with insurance or anything like that. And maybe this will be the next thing in how we manage rituximab, just trying to pursue that lowest dose possible. I don't know. What did you guys think? This seemed like kind of a big deal.
I thought it was a huge deal whenever I saw this. Like,
Yeah.
it's not that I treat any pemphigus or use any rituximab, but like that if you could read this as like we've been giving people 10 times the dose they need.
Yeah, and occasionally rituximab is FDA approved, but occasionally patients get stuck with like 3,000, 5,000. I don't. They're probably still going to have to hit that minimum on whatever their insurance is, but cost effectiveness, lower side effects, serious infections. It was a lower percentage even in that middle group. Now it wasn't statistically significant, but I think there's a lot of pretty good reasons to maybe start doing lower doses on these guys.
And with numbers this small, it would have to be a huge difference to be statistically significant. So it makes total sense to me. That to me, this should now be state of the art. 500 max, and maybe over time, like people are going to decide it's 100. But yeah, interesting. All right, let's move on to my first one of the day. So this was a twofer. So there were 2 things that came out that were really good. Number one, why do we see increased rates of cardiovascular events with tofacitinib in rheumatoid arthritis? And really, here's what was interesting about this. So it turns out TNF and IL-17 induce a prothrombotic state in your endothelial cells. So basically, the way that those 2 cytokines, the pathways that they activate, drive this procoagulant. They make some stuff go up, some stuff go down, but they drive a more procoagulant thing for TNF alpha and IL-17. And essentially what it comes down to is that TOFA doesn't reverse it. So it's a JAK3, and it really doesn't counteract this innate prothrombotic state of rheumatoid arthritis. Now the next question is, well, not that we're treating rheumatoid arthritis and derm, but would Rinvoq be different? And it may be, because it doesn't lower IL-10 because it has a different JAK selectivity. It maybe doesn't lower IL-10 as much, and it maybe suppresses IL-6 more. And both of those things would have a different. They would make it less likely to have any prothrombotic effects. But the really relevant thing is the next article that I want to talk about, and this was one I was a co-author on, is upadacitinib, i.e. Rinvoq, cardioprotective and chronic inflammatory diseases, review of major adverse cardiovascular events in venous thromboembolism and atopic dermatitis. And there's a really nice figure here that really shows that with all the studies that we have looking at the rates of MACE and VTE, the background rates in atopic dermatitis, they are lower on Rinvoq than the expected rates in the general atopic dermatitis population. My personal belief is that there's this Kaiser article where they specifically looked at a cohort that was intended to mimic the cohorts in the AD trials for all drugs. And that's, to me, my favorite comparator. And, the rates, if somebody came out with data nowadays that showed me that Rinvoq increased the rate of MACE or VTE in atopic derm, I would be like flabbergasted, like flabbergasted. gasted. I think there's so much data around this now, in multiple different ways, and it makes sense because now that we understand better why TOFA might have a prothrombotic effect, or at least not be antithrombotic. It's actually kind of a little more believed that it's just that it's not antithrombotic, is disease specific. So it's in a disease that's TNF and IL-17 driven, that's innately increasing the prothrombotic risk, and JAKs just might not reverse that the same way that drugs that directly target IL-17 or TNF or IL-23 do. So it really looks like these drugs act differently in the two different disease states. And that was kind of but it was interesting. It was the first time I really read something that I was like, okay, now I think I get it. I think I get now more about why we see this increased risk of Mason VTE in psoriasis and rheumatoid arthritis, while we don't see it in atopic dermatitis and alopecia areata and other diseases. So that was kind of it just was, now I feel like I finally have an answer for this that I've been wondering about it for a long time.
And it was
Interesting. I've always thought it was just the different patient populations. It's just a lower risk population with AD, right? They're younger, they don't have all the comorbidities. But there were some VTE events in the studies, but you're just saying not like we just like anchor onto them because we're looking for them.
Yes, and it's in rheumatoid arthritis. I believe the risk of Mason VTE is literally double compared to a matched population that does not have the disease. And in AD, there is not. There is not an increased risk when you compare to a matched population that does not have the disease.
I thought that the fact that the JAK inhibitors were up against the TNF, like specifically up against the TNF alpha inhibitor, like TNF alpha inhibition in RA is decreasing clot risk. And it's not like JAKs are making it worse, but
yes,
if
they're just not
TNF is
reversing it.
prothrombotic, then compared to a TNF blocker, it's not going to look good.
Yes, and I have never seen any data that shows, because we're never going to get like a placebo control. Hey, for your rheumatoid arthritis, go on placebo versus, Rinvoq for 5 years. Like, we're never going to see that study. It's always going to be Rinvoq versus, or not Rinvoq, Tofa, whatever, versus something. And TNFs and probably IL-17s, they reduce the risk. So it was first, because I always think it was just inflammation. It's inflammation. Yeah. And the takeaway from this was that no, IL-17A and TNF specifically induce a prothrombotic state in your endothelial cells.
And when you say that they matched the control, so one of the things I thought of with clinical trials, if you were within 6 months of having some cardiovascular event or VTE, that was exclusionary. You wouldn't be in the trial. If you're just looking at an atopic dermatitis population, you're going to have those people. So aren't the trials like selecting out maybe healthier people that aren't going to have the clotting issues? Or were you saying that one of the studies controlled for that?
Well, I think I was more talking on a epidemiology level. Okay. If they look at these people with the disease versus without the disease, kind of a matched control, that there's this big increase in RA that's above and beyond just what are your innate risk factors. All right, let's move on here. Ferris, what's your next article?
So my next one is clinical utility findings of a transcriptomic psoriasis biologic test demonstrate altered physician prescribing behaviors and improved patient outcomes, Strober et al. This is basically, and this is in dermatologic therapeutics. So this is the Mind.Px, this Mindera test that is supposed to help you to predict which biologic for psoriasis your patient should get. So what they did was they basically randomized patients who had moderate to severe psoriasis to who are either starting a biologic for the first time or switching to their second biologic to either get so everybody got this Mind.Px test done, and in one arm the physician got the result before they picked their biologic, and then in the second arm the physician just had to make their decision as usual, treatment as usual. So the primary outcomes they're looking at is physician prescribing behavior, and then also the patients reach a PASI 75, yes or no, at weeks 4 and 12. So 210 patients completed, although they enrolled 310 or screened. So it's kind of a higher dropout rate than you might expect. So how often did the physician pick what the test said to do? When they knew the result, 93% of the time. When they didn't know it, they picked the right drug 65% of the time. So this was statistically significantly different. So here's like where I'm like, I don't know what I think about this. They looked at PASI 75 responses. So first of all, PASI 75, we can do better than that, but that's the output, that's the outcome, primary clinical outcome that they looked at. And so more patients had a PASI 75 in the informed versus uninformed arm, both at week 4 and week 12. And they said, oh, this is like consistent with what we saw in historical controls. So, of the patients who who completed the study, 81% reached PASI 75 in the informed arm versus 54% in the treatment as usual. So, that's kind of a low number. So I was like, all right, I mean, what is like the expected, PASI 75 response? So even with no guidance, I think it should be higher than what they saw, than 54%. So I was like, let me go back and look at week 12 PASI 75 response. For etanercept, it's like, 49%. For adalimumab, it should be more like 65 or 70%. And, for IL-17s and IL-23s, it's kind of more like 80-ish percent, right?
Did
And so
they maybe count dropouts as, did they do like an intent to treat analysis? Is that
that
maybe
is
what?
that's not what I got from the
Okay. Huh.
methodology of this paper. So the other
Okay.
glaring omission is like, what drug did people actually get in both arms, right? So if everybody in the, in the test,
Yes.
we saw the test result got like risankizumab and everybody in the treatment as usual got etanercept, then that would explain it too.
Yeah, I could do
And
the
then I'm like,
same.
what's
I
that?
could do the same. I could do the same test by putting my finger on the patient. You will respond better to risankizumab,
Yes,
right? I
exactly.
mean,
So,
isn't
right.
that what?
In theory, this could be really good if it
Like a
told you
divining rod or something
Yeah,
like that. That'll be
right.
the next one.
That'd
right.
be if it tells you the 2/3 of people who are going to do good on a Humira biosimilar, like
Yes.
this could save a huge amount of money, but
Agreed. So
they need,
that would be
yeah.
like where this would be helpful. I just think like they didn't share enough data on like exactly what drug everybody got. And then like, they didn't, I presumably in the standard of care like arm, they still had to go through insurance, right? They didn't just say pick a drug and we'll give it to them. So like there was also probably a little bit of a bias in terms of like, what insurance dictated, and maybe with the result, they were able to follow the guidance of the test better if they had the
Yep.
insurance, if they had that result. So I think, the jury's still out to me on this test.
All right. So Ferris, wait, I got this chart that you made
Yeah.
with the PASI 75s. Which AI did you use for that? Because it's really good.
Perplexity AI. Don't give away all my
Okay.
secrets. Yeah.
And you put in like a prompt, like make me a table of from the
Of
phase.
week 4 and week 12, PASI 75 responses for, and I gave the names of the drugs.
And you didn't have to upload the papers or anything. You just said
No,
make me this
I
table.
had it go look for it and had it make it for me.
Did you
Yeah.
tell it? Did you tell it to get it from the package inserts, or
I
did
didn't
you?
tell it. I let it pick where to get it.
Okay.
But they
Well,
are, I mean, I kinda did like a little quick spot check that make
yeah,
sure
yeah,
it
yeah,
wasn't like, all AI hallucination.
yeah,
So,
yeah, yeah, yeah. Okay. Well, that's pretty interesting. So yeah, Mind.Px, maybe Min.Px, maybe great, maybe not. Hard to tell from this paper.
yeah, and the
That's
other thing is, like, I think about some of the papers we did recently where we're like, they failed one IL-23. Should you switch to another one? And the answer we kinda all came up with was, yeah, they do pretty well. So, it's hard for me to say you're a responder to a whole class based on all of the, like, within class versus intra versus interclass switching papers we've talked about.
although there was a study recently that, and I don't know if we covered it on the show, that did show a better response rate treatment they didn't do good enough. A better response rate with inter-class switching, but I think it was mostly a second IL-17 or switch to IL-23. But the inter-class switching did seem to be better. But it wasn't like failing one drug predicted the other one isn't going to work. It was just it's a little less certain it's going to work.
Right.
Yeah, we did cover that.
Okay.
We did.
All right, Patton, what do you got?
Second six-pack was from May 2025 edition of Journal of Cutaneous Medicine and Surgery. It was by Stearton et al. It was titled Therapeutic Drug Monitoring in Hidradenitis Suppurativa Patients with Suboptimal Treatment Response to Adalimumab. Cross-sectional study, 62 patients with HS managed at a single institution. So to be one of the 62 patients they included, you had to have moderate to severe HS. So this was based on Hurley alone. So Hurley stage 2-3. They were on adalimumab 40 or 80 milligrams weekly and a suboptimal clinical response, meaning
Is that difference just based on weight? Is it a weight? Like I don't really use a whole lot of Humira for treating HS. I put them on a clinical trial. Why were some on 40? Why are some on 80?
This having it at a single institution, I think, impacted this paper a lot because the way that they would practice at this institution is if you were on 40 and you were a suboptimal response and you were subtherapeutic on your adalimumab level, and they just set it at a particular level, like 10.6, whatever, micrograms per something. So if you were on 40, suboptimal response, subtherapeutic level, and had no anti-drug antibodies, you got bumped to 80. That was just how they did it. So if they're on 80, when they did this cross-sectional, it's just one point in time, but that's how they got to 80.
Okay,
from
so
what I gathered.
It wasn't like if you're over 220 pounds, you get 80 or something. Can you get 80 from insurance? Is that like
that? Yeah. So I mean, I kind of get into that at the end of the paper, but that's there's a lot of things in this paper that may actually be moot because of like when it was done, but we can talk about that at the end.
All right, go ahead.
So suboptimal clinical response meant worsening of their HS despite being on therapy for a minimum of 3 months. We talked about they would do therapeutic drug monitoring and they'd bump them up to 80. So in the final analysis, 51 patients on 40, 11 on 80. Percentages of similar were between the two groups. It was like a 60-40 split between therapeutic and subtherapeutic drug levels. So in the 40 suboptimal responses, 60% of the patients were suboptimal, even though they had a therapeutic dose, whereas 40% were at a subtherapeutic drug levels. And it was that same breakdown, kind of 60-40 in the 80 milligram weekly group. Tables 2 and 3 compared clinical characteristics. Nothing really stood out except that, and I am probably going to say this wrong, but I don't know. Well, I'll make a chart. Most patients with therapeutic levels were Hurley stage 2, so 78.1. This was just in the 40 milligram weekly. Most patients with subtherapeutic levels were Hurley stage 3, so 57.9 in the subtherapeutic were Hurley stage 3 versus whatever. Yeah. Drug antibodies didn't seem to play a huge role, but this was very confusing. So overall, only 4 of the 19 patients with the subtherapeutic drug levels in the 40 milligram group had anti-drug antibodies. So this is not subtherapeutic because you have anti-drug antibodies. It's just subtherapeutic. They don't know why. But at one point in the paper, they're like, we only check anti-drug antibody levels if the dose is like barely, like essentially 0. So did they really check anti-drug antibodies in everybody? I don't know. Another thing that stood out in the 80 milligram group, over 70% of those patients were on additional immunosuppressants that weren't characterized. Was it immunosuppressants to treat the HS? Was it immunosuppressants to decrease the likelihood of developing anti-drug antibodies? They didn't really say. So it seems like without stating it, or maybe they did state it explicitly, the authors would recommend that in patients with suboptimal control on 40 milligrams weekly, you would do what they do. Check drug levels, drug antibodies. If levels are low and there are no antibodies, bump them up to 80. Again, how did they do that with insurance? This was a study that was done in Canada. So maybe Canadian health system Yeah.
But this should be getting easier for us to do, though, with biosimilars. Like, who cares? Once you're paying for it, who cares if you give a second dose?
That's true. They don't really propose to what to do if you're a suboptimal response and on the 80 milligrams, like you bump it up to 120, 160. This was all done before. So in Canada, you can get the IL-17s. They are approved. So this was done before that was an option. So it was almost like this was the only option they had, because infliximab also, from what I understand, I mean, the quick reading I did, which might not be accurate, but it's also hard to get infliximab up there too. Whereas, at least my experience, it's not that hard to get infliximab for HS patients. So yeah, would I mess around with the adalimumab and doing all that and bumping them up to 80 if they're subtherapeutic without it? Probably not. At that point, I would say we need to switch either to infliximab, where we can weight-based dose it. And the other thing that's nice about insurance with infliximab is, if you say, I want to do it every 6 weeks, they're like, fine. And then if you call them and say, well, I want to bump up the dose and I want to do it every 4 weeks, I have not had problems with insurances saying, no, you can't do that. They really cover, like, once they say, okay, I'll cover the infliximab, they'll cover any dose, any frequency. Where I am at now with HS, though, is, do I do that before the 17s? I do think the TNFs might be a little bit more effective, and it's very nice with infliximab to have that flexibility with dosing and frequency. But if you have a failure in adalimumab, where do you think you guys are going next? 17s or infliximab?
I mean, I think the TNFs are clearly riskier than, and not, I don't think it's a huge risk, because other people are dying, keeling over with horrible infections. But I think of the TNFs as riskier. I don't know. I
Mostly
would go
infectious.
Infectious.
And infliximab has a higher infection risk than adalimumab. I mean, probably just because of the doses, particularly the therapeutic doses. I'm going IL-17 if my first pass TNF, if my adalimumab doesn't work, if I can get IL-17 and IL-17. Yeah.
The other thing I'll throw in there is sprinkle some roflumilast in, right? If they're like not doing well enough, because there's no reason to not use roflumilast together with a biologic, right? There's no additive immunosuppression.
Right.
Might be easier than trying to switch over to a whole different drug and get
Study we need to do.
another prior auth, right?
Right.
Well.
All right, I'm going to jump over. We're going to jump to my last article, which was scabies, right? So the first, let me give you my scabies pearl. Do not ever say the word scabies to a patient until you are sure they have scabies. So the way that you've got this itchy rash. I'm really excited. I think you might have this weird skin infection. It'd be the best thing that you could ever have, because it's totally curable. So I'm really hoping that this is what you've got, because otherwise you're going to really suffer with this for a long time. But if it's this infection, we're going to cure you easy, piece of cake. Like, oh my God, I hope I've got it. I hope I've got it. But was there a name to it? Don't worry about it. I'll tell you after I go look at this under the microscope.
Wait a minute, do you get away with that? I'd be like, what, you don't know the name?
Well, at some point you got to tell them.
I have to go look it up.
But you got to you build it up first. You build it up as this is what you want to have.
All right.
You get them excited. You get them
I
excited.
do tell
for
people
the
that all the time. I do give them the name scabies, but I say, like, the best. I'm really hoping you have scabies.
But just throw the scabies. So really what happens is I have that whole discussion. They're like, oh, they're all excited. And then they're like, well, what's the name of it? Then I'm like, it's called scabies. And then they're like, oh, but I'm not dirty. And I'm like, I know you're not dirty, but let's really hope you've got this, right? The other thing that I tell people all the time is that I think scabies is way less contagious than it used to be, because of just better personal hygiene. That, we're showering every day, we're using all of our soaps, everything else. But I always tell people that I think it's bad luck, because scabies happens to live in the skin, in the web, in the spaces between your fingers. So it's just, you shake hands with the wrong person, you catch it, and then you're just never going to get rid of it until we treat you the right way. Come on.
It's
I don't think you can get it from shaking
There's a
somebody's
different
hand.
kind of skin-to-skin contact that I believe is the major risk factor. But go ahead. Maybe it's Also, like the people who get herpes from toilet seats, they might also get scabies from shaking hands.
Right? It's it's possible.
It's possible.
It's possible, right there in your finger webs. All
Yeah.
right, so
Okay.
this article, Scabies Management Outcomes, Identification of Risk Factors for Treatment Success or Failure. Basically, this was in Germany where they have like very strict guidelines. And so basically they looked at people who either their scabies quickly cleared or quickly did not. So it was relatively short follow-up. And I think if you had scabies for a long time, it takes longer to get better, but relatively short follow-up. And here's what they found. So first, 97% of people got permethrin, mostly twice. But what mattered, leaving it on longer than 12 hours was more likely in the treatment success group. Getting someone to help you put it on so you get it in all the cracks and crevices, that mattered. And then second, adding ivermectin mattered. So just both using ivermectin and doing 2 doses of ivermectin, that was people were more likely to be in the treatment success group. And to me, this is one of the first places I've really seen this, but to me, that should be standard of care for all scabies now is permethrin. Like you do your permethrin and ivermectin on the same day, then a week later you repeat the permethrin and ivermectin. Because we know permethrin, if you use it correctly, is more effective than ivermectin, but it's just like sunscreen, right? People don't put it on thick enough, they don't get everywhere, the blah blah blah. So to me now, this really supports the idea that standard of care should be permethrin plus ivermectin orally, because right, ivermectin is such a cheap, safe drug.
And over the
Second thing,
counter in lots of places soon. So it'll
get it
be
right,
really
going
easy.
over the counter now,
Yeah,
which that's an interesting whole nother debate.
that is.
But then the other thing, they also looked at treating the environment and things that correlate with being more likely to be in the treatment success group was changing your bed linens daily for 4 days after application, storing your clothes in plastic bags for 4 days seemed to make a difference, and then vacuuming carpets and car seats seemed to matter. There were a bunch of things that didn't seem to matter. Things like getting your carpets disinfected, getting them professionally cleaned, you know, disinfecting your car seats didn't seem to matter. Getting your car seats professionally steam cleaned or whatever didn't seem to matter. So it seemed like vacuuming was a useful thing in general. Uh, and then the changing the bed sheets and the putting your clothes. But this wasn't like a randomized trial where they told do this, don't do that. It was so who knows, maybe those measures were just a marker of they put the permethrin on better or something like that. But those were the big takeaways. So vacuuming your furniture, your car seats, and your carpet seemed to matter. Changing your bed sheets daily for 4 days after each treatment seemed to matter. And then for clothes, putting them in a plastic bag and leaving them in there for 4 days seemed to matter. Those were the big takeaways. What do you guys tell people to do? But when you do you like really go into the like, whoa, you got to really clean everything and the la da da da, or
I
you're more like,
probably don't
the
enough.
drug's gonna work. Just
Yeah,
treat
I
yourself with the
I
drug.
also think, like, if you use both drugs together, it's generally gonna work. I tell them wash their sheets the morning after their application of permethrin, and then, each time. That's kinda what I say, and, like, wash all your clothes, and that's all that I tell them to do.
Patton.
Same. Yeah.
Okay.
I
And I will be very honest. The way that I treat scabies, whenever I'm sure it's scabies, I do ivermectin 400 micrograms per kilogram, so double the normal dose, combined with permethrin, and I repeat it weekly for 4 weeks. Because like, why not treat the hell out of them? Is there, they're such safe drugs. Uh, it just that makes way, way, way more sense to me to treat them very aggressively like that. Uh, so that's my scabies pearl. The other thing, if you don't know about this, most useful diagnostic advance in the history of dermatology in our lifetimes. Do you guys? I don't know if you talked about this. Scabies fluoresces. and it's a very specific, obvious thing on Wood's light. So the mite fluoresces a bright yellow, and then the burrow fluoresces like a pale white behind it. Like if you think somebody might have scabies, you should never scrape them until you have Wood's lighted them, because it is the first thing ever that tells you where to scrape. Like dermoscopy was worthless because it's still dermoscopy in the right spot. You can Wood's light their whole body in like 30 seconds, and it tells you exactly where to scrape. And to me, it is and this, I'm not making this up. It's published. Like there's a couple of studies looking at this. It's just Wood's lighting scabies is like a big, that was a big advance. I can't believe nobody figured that out like 50 years ago. Very disappointing in our ancestor colleagues.
No, I have not used Wood's lamp. I do use dermoscopy. I do actually sometimes find it helpful for finding where the mite is, but I need to start doing Wood's lamp because sometimes it's like, where exactly do I look? So yeah.
And it just makes me feel better about when I'm like, I don't think I got scabies. I'm now a lot more certain that somebody doesn't have it. But so that's the takeaway. All right. So I want to thank everybody for joining us today. If you've got questions, comments, ideas for topics we should cover on the show, shoot us an email, questions@dermsondrugs.com. Hope you learned a few things. Hope you laughed once or twice, and mostly we're hoping you're planning to join us next week. Till then, I'm Matt Zyrus.
I'm Tim Patton.
And I'm Laura Ferris, and we are Derms on Drugs.